Good afternoon and welcome everyone to today's second webinar celebrating Spiritual Care Week, How Research Informs My Chaplaincy Practice. I'm Andrew Andresco, Project Coordinator for Transforming Chaplaincy, and we are delighted you could all join us. A couple of housekeeping instructions off the top. You are listening in using your computer speaker system by default and are muted. Should you have any technical questions regarding your audio visual, please type those into the chat box located in the platform's dashboard. You will have the opportunity to submit text questions to our panel by typing those questions into the questions pane of that same control panel that's located at the side of your screen. You may send in your questions at any time during the presentation. We will collect these and hope to address as many as we can during the Q&A session at the end of today's event. With that, I'd like to introduce Ginny Werpsa, Research Chaplain, Department of Spiritual Care and Education, and the Program Manager and Clinical Ethicist of the Ethics Program at Northwestern Memorial Hospital. Jeannie?
Great, thank you. Welcome, everyone. Really glad to see you all, although I can only really see our panelists, but I'm assuming there's a vast audience out there, a cloud of witnesses. No, glad to be here celebrating Spiritual Care Week and focusing on this topic near and dear to my heart, which is a very practical presentation today. How is it that research actually informs our practice as chaplains? How do we take this evidence-based practice that we have, the evidence that's there, and translate it into our daily care for patients, as well as program level spiritual care initiatives. So that's what we'll be doing today. I'm thrilled to welcome our panelists. Let's see if I can get there. Dr. Marilyn Barnes, who is now the chair of patient counseling at the College of Health Professions in Virginia and Commonwealth University. Wave your hand. Beth Reese, manager for spiritual care at the Shirley Ryan Ability Lab here next door in Chicago. And Kristen Schenk, a longtime friend and chaplain at the Ann and Robert H. Lurie Children's Hospital here in Chicago as well. I've had the privilege of working very closely with these stellar chaplains and educators. So thanks for being with us. Today, we are going to invite each of our panelists to talk about an area where they have directly applied research in their care. I just want to remind folks, kind of when we think about evidence-based practice, which is what we're talking about today, and we have heard that term a lot recently. If you watch the video for Spiritual Care Week, you probably hear the word evidence and evidence-based about 50 billion times in that. What are we talking about, right? We're talking about, again, best scientific evidence that's out there. And that may be limited in some areas of care. Certainly, we know that the research available to chaplains and on chaplaincy care specifically is rather limited at this point. We have some, but we don't have a lot. But there is scientific evidence in other areas, as you will hear. We don't just take that and apply it like a wooden framework onto the care we're giving. Evidence-based practice asks us to bring our clinical expertise and experience, our judgment about what's appropriate in this situation into conversation with the best scientific evidence, and to then take into account who this patient is or who this system is or this organization before us. So it really is this lovely dance between these three areas. And each of our presenters today has become experts at that dance, so you will hear from them. And after they've had a chance to talk about their area, we'll invite them to share some tips for you all and to, of course, answer your questions and potentially hear your suggestions. As Andrew said, the only way to communicate on this platform is to type your responses, questions into the questions section. So please do that. Okay. So now, Kristen Schenk, start us off.
Thank you. Good afternoon, everyone. As Jeannie said, I am a chaplain at Lurie Children's Hospital here in Chicago, and I've been here since 2017 in a couple different chaplain roles. I've also been involved in some spiritual care research projects through RUSH and with the Transforming Chaplaincy Pediatric Research Network. Jeannie says we're experts. I don't personally consider myself an expert, but research does play an important role in how I approach my clinical work. So I'm really excited to talk today about one article that has impacted my practice. Next slide, please. So there are a number of reasons that we as chaplains engage in research and seek to be research literate. And all of those do play an important role in the evolution of our profession and our clinical practice. While staying current on research in our field and related interdisciplinary fields helps me personally to feel more equipped to critically examine some of the practices of chaplaincy and to talk with other colleagues about what we do. For me personally, it's the caring and improving aspect that I consider to be at the heart of my own draw to research. Whether it's a large, rigorous study or something that is smaller and investigatory and trying to lay the groundwork for future research, when I read about chaplaincy research endeavors, I try to approach it with a critical lens, asking things like, what can I take away from this? How can I critically examine parts of my own practice? How can I do a better job accompanying patients and their loved ones? And ultimately, how can I improve the support I offer? Next slide, please. So the article I've chosen to focus on today falls somewhere in the middle of the research hierarchy, but it's definitely a bit closer to the bottom than it would be to like a randomized controlled trial. The article itself is called Hospital Chaplains Through the Eyes of Parents of Hospitalized Children, and it was published in the Journal of Palliative Medicine in 2017. The title makes obvious that this study hones in on pediatric patients and their loved ones, but I do think there are takeaways for all of you listening, those of us who work not only in pediatrics, but also adult healthcare and even other settings. I've presented this article to a few groups of Jeannie's CPE residents at Northwestern, so when she asked me to talk about it here, even though it's a few years old, I was really excited to do so. I have personally found that the findings and insights in this article are really relevant and regularly resurface for me as I think about what I do at Lurie, especially with parents who are the primary ones who I interact with. Next slide, please. So just to give you a bird's eye view of the study itself, this study was conducted at Johns Hopkins Pediatric Hospital in Baltimore by an interdisciplinary team of researchers that included 2 people from the spiritual care department. They knew some of the background on chaplain availability in hospitals and on the roles of faith and religion for people facing medical challenges from other research that had been done, but they wanted to better understand how families of hospitalized children viewed and utilized hospital chaplains in order to help guide hospital chaplain practice as it relates to children and families. There's, as Jeannie said, a growing body of research about chaplains, especially in adult settings, but there's a lot less for pediatric settings. So researchers wanted to see if they could learn more about how chaplains are viewed by parents and caregivers in this environment. The team hypothesized that most families experience chaplain visits as supportive, but that those who maybe weren't religiously affiliated might find visits intrusive, and that some caregivers might find visits, unsolicited visits, frightening if they were associated with end-of-life care. Next slide, please. So any parent of a hospitalized child who is visited by a chaplain or a CPE student in calendar year 2013 was eligible to be included in this study. The researchers talk about parents of patients, but there were a few other caregivers included who are not parents, who are grandparents or guardians or other adults in the child's life. Now, of those eligible to participate, only 29% ended up joining the study and completing the phone survey. The phone survey included several types of questions that could be analyzed both qualitatively and quantitatively. So researchers used a few different analytic tools to examine the data they obtained. Next slide, please. Just a couple of quick limitations before I talk about the results and what they have meant to my practice. First, this was a small study that occurred at one site only. According to the researchers, the hospital itself usually has high levels of acuity and only a small number of chaplains. So there's a good chance that chaplains ended up seeing fewer patients, or excuse me, fewer parents of patients on general medicine floors and more parents of children who are in critical condition. So that might have influenced a parent's desire for an interaction with a chaplain. Second, we don't know whether those who did not opt into this study had adverse encounters with chaplains. Their input could have revealed further insights or impacted the statistics from this study. Given that there's a high percentage of respondents who did identify as religious or spiritual, they may have been more inclined to participate. Third, the researchers noted that most respondents were female, so we don't know how responses might have been different if more men had responded. And finally, I didn't list it here, but the data in the study is now 7 to 8 years old. So it's important to note that the religious and spiritual makeup of the US has continued to evolve since then. Next slide, please. So there are several detailed tables in the article, as well as more extensive discussion about the findings. So I'd encourage you to take a look at that, but these are some key takeaways that have been important for me. First of all, 90% of the respondents in this study considered themselves religious or spiritual, which is a bit higher than the national average and worth noting as a limitation. But it doesn't negate what the researchers found, because we definitely have religious and spiritual patients across all of our hospitals. So these takeaways could potentially be applied to them. 3/4 of those who participated viewed the chaplain as at least somewhat a part of the team. For me, this can speak to our ability to kind of hold that line between being part of the team, but still being removed enough to make a different connection with the family than maybe the doctors or nurses. 30% of parents and caregivers said that the chaplain helps the team understand their preferences, usually or always. Given that we profess to provide support in complex decision-making processes, I see this as an indicator of a lot of room for improvement, and I'll come back to that in a little bit. And almost 85% of respondents said a chaplain visit was very or somewhat important during their child's hospitalization. I think that's huge and speaks to the role that we can play when we are able to make a connection with the family and extend that support to them. Next slide, please. Over 50% of survey respondents said that the chaplain usually or always responded to their concerns. I think a lot of this has to do with our active listening skills, but I also think this is lower than what I would like to see personally and what I hope families are taking away from their encounters with me as a chaplain. But I also think it's important to note that how a participant defines a response to concerns may vary, and also we're not there to fix problems necessarily. So, you know, there's some variability here in how the question may have come across. 51% of respondents said the chaplain helps them find meaning in their child's illness. Again, a good number, but a lot of room for improvement and something to keep in mind as we approach visits. 65% said the chaplain visit impacted their overall hospital rating. In an industry such as healthcare, where so much is driven by patient and family satisfaction and the bottom line, this is a really important finding when managers of a department are trying to make a case for the value that we add to patient and family experiences. And lastly, both religious and non-religious parents and caregivers highly affirm that chaplains help them cope with stress and maintain hope through their child's hospitalization. Researchers found very few differences between these two groups in regards to how they perceive chaplains. Next slide, please. Now, I personally like numbers, but I find survey comments often provide even more insight and clarity from participants. So here are a few comments and how they have applied to how I see myself functioning as a chaplain. So one parent said, single patient rooms are nice, but isolate parents from the support of other parents. Chaplains are key. For me, this speaks to the element of connection that I can help to provide. Being a sounding board, a processing space, someone who can help normalize a whole range of feelings can be a huge support to a caregiver. Especially during COVID, this has felt really true, given that visitors to our hospital have been so restricted and patients and their loved ones have been even more isolated from support they would normally be able to access. I also think about this comment in relation to caregivers who ask about other resources available to them. And I try to make a point of keeping current on what support groups might be available on a given hospital unit and more broadly in the community, so that parents can access that connection that they need. Another parent said it's nice to have a chaplain visit because you feel a burden to others with your problems, but chaplains are there for just this type of thing. So for me, this points to the role I can and do play beyond just religious and spiritual support. It reminds me that many loved ones do not feel that they have adequate outlets to reflect on their challenges and grief, and so I can try to create a space where they can do this in the hospital. Next slide, please. Another parent said, we are grateful for the care, but would have liked continuous care with just one chaplain. Obviously, this isn't possible for all hospitals, or most even if they have a lot of chaplains on staff. But this comment emphasizes to me how important continuity of care can be when it is possible. It can be really draining for families to have to tell their story multiple times to many providers, so it's important to me to try to follow up personally with families when I can, and also to collaborate with chaplain colleagues on the units to be intentional about any unsolicited visits, especially if they have existing relationships with families, and let them kind of take the lead on that. The first comment on this slide says, no one initiated a visit with a chaplain. We've been in many hospitals and a chaplain usually visits. I was disappointed with Johns Hopkins. Now remember, to be in this study, a parent had to have at least one documented visit from a chaplain. So this comment is intriguing, and there could be some reasons, such as maybe the other parent was present when a chaplain came by, or there was another confounding factor. But it does make me reflect on how I introduce myself and define my role to caregivers. Another parent said, even though we are not religious, the chaplain was very supportive during a long hospitalization. If asked, we would have turned down a chaplain visit, but chaplains should visit all patients and families. And these two comments together invite me to reflect more on what I do, how I describe it to patients and their families, and how I navigate those introductory conversations before I know a lot about a family's religion, spirituality, or worldview, and how receptive they might be to a chaplain based on their preconceived ideas of what we do. Next slide, please. So a few other takeaways before I wrap up. First, this study raises questions for me, like I said in the last slide, about how I describe who I am and what I provide. As an example, when I respond to a trauma or a high acuity event where a family is new to me, I assess the situation and decide whether to introduce myself very clearly as a chaplain or more vaguely, especially if it's a potential end-of-life situation and I don't know how a family will perceive a chaplain presence, to introduce myself as a member of the family services team who can, among other things, provide spiritual support. For the second and third points here about being a bridge between the family and the care team and about collaboration, I feel like there's a lot of room for improvement across our profession, including for myself. In this study, only 30% of parents said a chaplain helps the team understand their preferences, usually or always. So for me, when I finish a visit, I try to make a point of thinking about what was shared with me in light of who on the care team might benefit from knowing it. Obviously respecting family and patient confidentiality, but if there are pieces of information I gain from that conversation that would help another provider in their delivery of care, I want to be able to convey that information. I also think it's important to try to be present on the units to build relationships with staff so that they are familiar with me and so that I can serve as a bridge with them and they with me to jointly ensure that a family is heard and has their needs met. Next slide, please. I'm going to skip this first point for the sake of time, but I've touched on it a bit in the past couple of slides regarding my role. For the second point, this study and others has prompted me to think about my work in a much larger context. In this study, about 2/3 of parents said that chaplain support positively influenced their overall satisfaction with hospital care. That's really important to me. Providing personalized, individual, and evidence-based support is my goal with each encounter I have with a patient or their loved ones. But I think it's also really important to hospital administrators and leadership to understand that what we do does influence how families view their entire hospitalization. My perspective on a day-to-day basis is often geared towards the individuals in front of me, but I really value being able to situate my work in a larger picture too. And finally, while I found a lot of thought-provoking ideas and insights from this study, even in the 3 years since I first read it, I know I still have to keep in mind the limitations that it has and not treat the findings as absolute. There are differences between my hospital and Johns Hopkins, between patient populations and city and regional cultures, between general demographics. And as much as I would love to see a study like this done on a national level, to see if the findings would be similar or if there'd be different takeaways, there are still a lot of really key individual learnings that this study has provided for me. Next slide. So as I said at the beginning, I I have found a lot of takeaways in this article, and I think they can be applicable to many of your settings. I think we definitely need a larger, more representative sample for this to be generalizable on a larger scale, but I would just encourage you, the same way that I've tried to, in a very short period of time, show you how I've applied some of these findings, I would encourage you to think about some of these questions on this slide as you read research and apply it to your own environment and setting. I encourage you to keep an open mind and to think critically, both of those, as you read research. And with that, I will pass it off to Marilyn for her presentation. I look forward to any questions at the end of our 3 presentations. Thank you.
Thank you, Kristen. Marilyn, all yours.
Thank you.
Move to the next slide. There we go.
Thank you. Thank you to Transforming Chaplaincy for the opportunity to share how research informs my practice through the engagement of the advocate Chaplaincy Taxonomy. Research that is very near and dear to my heart, and I was grateful to be a part of the development of the Chaplaincy Taxonomy and look forward to sharing. Next slide. As a chaplain, I might say I spent time with a family after their loved one died. Another chaplain might say I sat with the doctor after one of their patients died, while another might say they spent time listening to a colleague share their concerns about missing their child's graduation because no one could cover their shift. When asking each chaplain to summarize in a few words their intended effect for the spiritual care interventions, there would be 3 different answers. The goal of the taxonomy is to have common terminology, a normative language for chaplains. Thus, each chaplain would not have 3 different answers, yet one, that they journeyed with someone in the grief process. Next slide, please. So why this research? Why is it important? Well, prior to the Chaplaincy Taxonomy, there was no normative language for chaplains, nothing to consistently define what chaplains do. This research set out to define things uniformly, focusing on providing a resource to enhance communication and to enhance research on chaplaincy outcomes and their association with health outcomes. Next slide. The research team used both quantitative and qualitative research methods. Back one slide, please. The research team began with a literature review of the work cited in the research proposal to categorize the chaplain activities and interventions to inform the retrospective chart reviews and the focus groups. The retrospective chart review step was 150 electronic medical records were reviewed looking at documented interventions of ICU chaplains at 3 level 1 trauma center hospitals. We conducted 5 focus groups, and along with key informant interviews, those were primarily with the leadership in chaplaincy in the healthcare system, with the goal of adding and deleting items from the draft taxonomy. Now, during the self-evaluation phase, chaplains documented activities and interventions from their interactions with patients, families, and staff. When we got to the experience sampling phase, the chaplains captured behaviors, thoughts, and feelings in real time, receiving up to 6 pages per day in addition to their normal duty pager coverage. And they would document what they were doing exactly at that time. So it could be that they were attending to a trauma or a death or spending time with a care team member or even having lunch. For the concept mapping phase, board certified chaplains and those board certified eligible from various parts of the United States took a look at the taxonomy in its current state, which was 107 items, and captured the frequency and importance of those items that they reviewed. The top 4 frequency items were active listening, provide a pastoral presence, demonstrate caring and concern, preserve dignity and respect. While the top 4 importance items were active listening, demonstrate caring and concern, provide a pastoral presence, and preserve dignity and respect. The last phase, next to last phase, was reliability testing, which focused on the scientific integrity of the taxonomy through the development of vignettes that were used to train chaplains on how to use the taxonomy, and then testing the taxonomy the instrument for its reliability of use. Finally, each one of the 3 research chaplains wrote 2 case studies utilizing the taxonomy. Next slide. The Chapmancy Taxonomy is comprised of 100 items, 15 intended effects, the why, the goals, or the outcomes, if you will, 26 methods, the how, or the bridge between the intended effects and the interventions, and 59 interventions, the what, the action, the both verbal and nonverbal that chaplains provide in spiritual care encounters. Next slide, please. With the intended effects, methods, and interventions, a chaplain can be prescriptive in developing a spiritual care plan in response to their spiritual care assessment, and also be descriptive in the care offered. Through the development of pathways that can have a single or multiple taxonomy items as reflected in this slide. So you can have one intended effect, one method, and many interventions, or you can have many interventions, intended effects, one method, and one intervention. Some of the top pathways used by chaplains in a palliative care setting included preserve dignity and respect, communicate patients' needs and concerns to others, and collaborate with the team member. Meaning making, through inviting someone to reminisce and encouraging self-reflection. Offer a sense of peace, pray for healing, and exploring hope. Next slide, please. Integrating the taxonomy into practice, the Mission and Spiritual Care Department at Advocate Aurora Health incorporated the taxonomy into the electronic medical record. The taxonomy is also included in other electronic medical records in other healthcare systems, as well as the armed forces. The use of the taxonomy facilitates the chaplain being more focused in their spiritual care plan through the building of pathways and documenting their goals and interventions. The taxonomy is also integrated into chaplain education. Chaplain learners are integrating the taxonomy into their verbatims, and through the use of spiritual care simulation vignettes, they're able to actually utilize the taxonomy for developing their spiritual care plan, as well as reassessing and developing another plan and engaging the action reflection model. In one particular case, as I was serving as a clinical chaplain, I offered spiritual care to a family whose child was an organ donor. Was a long spiritual care encounter, and at the end of that encounter, I documented my spiritual care to be descriptive, of the encounters that the spiritual care encounter. I had 20+ pathways describing the interventions and care that I had offered and how I was able to link it to the outcomes with that family. Next slide, please. Each of the advocate chaplains, as well as other chaplains throughout the world, have been trained to use the Chaplaincy taxonomy. This training includes developing a spiritual care plan, as I alluded to previously, utilizing pathways that have the intended effect, methods, and interventions. The development of a spiritual care plan in response to the spiritual care assessment has two impacts in clinical practice. One, fostering a focused mindset on developing a spiritual care plan, and two, clearly documenting the goals and interventions offered during a spiritual care encounter. This leads to the ability to conduct research on what chaplains do, with clear definitions of spiritual care goals and interventions as input for spiritual care departments to develop strategic plans that integrate what chaplains do and the association of the goals of the interventions with health outcomes. I look forward to our continued conversation around this current research, and I will hand it over to my colleague.
Well, thank you, Marilyn, and thank you, Kristen, for your presentation. So in my section, I'd like to illustrate how mindfulness and post-traumatic growth research helped us put together our programs for flourishing and wellness of staff and patients at our hospital. Next. So we are a translational research hospital, which means that research interacts with every facet of us. So it would be natural for us to turn to research as guide and wisdom for what we wanted to do with staff. We're very concerned about the care of our staff. It's a given that if you work in healthcare, you have high stress, struggle with giving bottomless compassion, burnout, fatigue, have little time for taking care of yourself, and all of that has been accentuated in the past year and a half. So as we searched for ways to care for staff, mindfulness came up again and again as a documented resource for lowering of stress and improving wellness. So we started there. Next. So we looked at a review of literature about mindfulness, 56 reports from the Department of Psychiatry at the University of Ottawa, which suggested that one way to combat compassion fatigue is to introduce mindfulness interventions. Its beneficial impact helps promote empathy, compassion, and self-care. And other mindfulness studies showed lower levels of perceived stress, decreased ruminative thoughts, and increased ratings of self-compassion, and that mindfulness allows for greater clarity in developing self-compassion. And finally, mindfulness functions as a viable tool in promoting self-care and well-being. So many articles all saying the same thing: mindfulness works in ways we need it to for professionals in healthcare. And the studies also indicated that stress and burnout and compassion fatigue are going to continue to be issues facing healthcare workers. And moreover, burnout has been associated with suboptimal patient care. And that touches a very sensitive bottom line for all hospitals, patient satisfaction. So we were on solid ground to think of offering this to our staff. And as both mindfulness and self-compassion have deep spiritual roots, it made sense for our department to be the major conveyors of these healthful practices. So our challenge became, what kind of structure should we have? What should be the content, and how do we offer it for our hospital, and who gets it? Next slide. So, and you can go on to the next one, let's see. So the research report from England stated that organizational changes were needed to model and reward self-compassion. And that report gave us another clue: frequency matters. It's not just a one-time thing. And their course for hospital staff included the following: emphasis on self-care, healing, mindful communication, didactic content, how the mind works, how stress impacts, means of coping with stressors, importance of self-care, experiential aspects, including exercises and communication, mind-body connection, and the effect of developing a meditation practice or a habit of mindfulness. So now we had more clues and a checklist to structure a program. Next. So what also helped was that I didn't have to convince anybody that this was legitimate. Evidence-based research did that for us. Next. So using Laura Lipsky's trauma stewardship, we started by building a 5-hour self-care program for nurses. It's given to new nurses over 5 months in their in-house training. It's been offered to interdisciplinary teams on the floors during their once-a-month all-staff meetings, and it's been offered in condensed form to our social workers, ethics department, and HR. And we put it together based on more discoveries. Researchers found a correlation between increased emotional expression and growth. Those who didn't express their emotions experienced less growth or didn't grow at all. So at the first session of this, we name the feelings, emotions, and traumas that result from working in the high-stress healthcare environment, like feeling helpless and hopeless, a sense that one can never do enough, hypervigilance, diminished creativity, and others. And we discuss shame, anger, and fear, 3 strong emotions with high energy that are gifts, but often are held and used in wrong ways. Next. So a study of 41 cancer patients conducted in Italy found problem-solving coping was a key element that contributed to growth. This gives a new sense of purpose and self-esteem as participants gain new meanings and initiated changes. So the next 4 hours are devoted to identity. Who are you and why are you here? Community. Who do you belong to and who belongs to you? Focus. What do you want and how will you get it? How will you set goals that get you there? And balance, that includes discussion about gratefulness, congruency, physical exercise, and making room for the good activities that fall away when we're under stress. Every segment has a worksheet to be completed and discussed in class, and every segment has a mindfulness relaxation exercise at the end. And we've begun to do some initial qualitative measures of effectiveness on this program, and nurses are showing increased awareness of vicarious traumas and appropriate tools to cope. Next. So follow-up is important and practice is important. And because research says there needs to be a way to keep this knowledge and awareness going, 10-minute mini relaxation sessions called Still or Pause are offered to nurses and PCTs on the individual floors, along with aromatherapy at least once or twice a week. Next. Using mindfulness and relaxation exercises for our patients too has an additional benefit that it often opens a door for conversation with a patient who might have said, no, I don't need a chaplain, but some of these other things they're open to. In another initiative, we offered an hour of instruction on mindfulness meditation, discussion of stress and anxiety, and resources for practicing at home to pulmonary outpatients. So why an hour? Well, this was new to many patients, and research showed that a listing of the benefits and a guided practice would enhance participation. So opportunity was given for debrief at the end, which included problem solving, what to do when your mind wanders, or how to incorporate this into your day. And I reminded them that research says frequency matters. And outpatient blood pressure levels were measured before and after the hour, and they decreased significantly, which pleased the outpatient therapy group and was a graphic example to the patients of the effectiveness of practicing mindfulness. Next. And we realized there was more we could implement. Studies of growth after trauma underline the importance of using strategies to recover from trauma. In the late 1980s, psychologists from the US, England, and India found that people can and do recover from trauma if given certain tools named by the thousands of people who had undergone trauma worldwide and were interviewed. While all our religious traditions teach that out of suffering often comes new growth and life, It was great that science could affirm this and give us tools to facilitate. And so it was named post-traumatic growth. Next. So this meta-analysis, 13 studies with over 33,000 participants, showed that positive change can happen in the wake of traumatic events. Post-traumatic growth goes beyond recovery to something more positive emerging from the negative experience. It's not simply a return to the baseline after a period of suffering. It's an experience of improved functioning, and not only for the mind, but the body too. Next. And here's how they name those changes. Increased inner strength, openness to new possibilities in life, closer and often deeper relationships with friends and family, an enhanced appreciation of life, and a stronger sense of spirituality. We wanted this for all our patients. Next. And research named the tools which helped people do this. So the first one was narrative, having the opportunity to tell your story, truth-telling, facing reality as it really is, inserting the experience of trauma into your lifelong story, community and support, finding hope, creativity, openness to new experiences, new identities, how will I go on from here, and faith. Next. And so as a result of this research, which is now pouring out as a way to recover from PTSD, the traumas of our COVID year, and other traumas that we're all experiencing, we have a grid to place over our care, a way to evaluate what's needed and what might be missing. And as we considered these tools, we became aware that a missing tool for us was community for patients. And so we started support groups for limb loss, complicated diagnosis, stroke, and families of patients on our brain injury floors. And the response was tremendous. Patients begged to come back. All kinds of emotional healing was happening in these groups. Next. So based on this structure of knowing that storytelling and community is so important to healing, we started what was called a staff ritual. That's a half an hour of sharing about what it's been like for staff in this very, very stressful year. 6 or 7 staff members at a time, that's all you can do in a half an hour. Nobody can spare more. Across departments, in the chapel, using votive lights and river stones. Also to great reviews of staff who participated. Next. And with ethics, we've held resilience rounds where a department or floor staff explores a patient experience or an issue together, which also involves storytelling in community and creative reframing. So while some of these initiatives were put on hold during COVID, like aromatherapy and some of the group work, we've been slowly and carefully restoring them. So hopefully I've illustrated how we've incorporated mindfulness and post-traumatic growth into so many of the initiatives that we're putting out at the Ability Lab. And next. In closing, I want to say that research has helped us identify, program, and affirm all of this. Research legitimizes our efforts. It makes management willing to listen to our proposals. It clarifies our purpose. What are we trying to accomplish? And how will we know if this helps? And how can we improve? All of these answers will come from research. Thank you.
Oops, trying to move forward here. Thank you, Beth. There we go. So we do have some questions coming in, but I'd first like to engage our panel in a few questions that we came up with in advance, really to try to give some tips for chaplains anticipating some of the barriers. And again, any of our panelists can jump in and answer these questions. You may not each have something to add. We know that many chaplains may be reluctant to integrate research into their practice, mostly because of this sense that we have that they want to enter the room without an agenda, meet the patient where they're at, right? That's been kind of hammered into us for so long. So what suggestions do you have to address this concern as we're trying to, again, bring some gems, some insights, some structure, some tools from research into our practice? And again, any one of you, please take yourselves off mute and jump in.
Well, I can start with that. I would say that absolutely I want to walk into a room without an agenda. Who knows what will open up and in what direction. But research for me has been about putting tools in my toolbox. And so when I go into that room, the more tools I have in there that I can use with the patient, the better. So I don't see it at all as research directing my agenda. I see it as just this multiplication of ways that I can help open up storytelling or put words to what's happening, or you know, even like a brain injury patient, research has showed that aromatherapy opens up the ability of the brain to receive oxygen with frankincense. So, you know, maybe I use that, but you know, all of these things are just tools.
Kristen or Marilyn, anything to add?
I would say I too don't walk in with an agenda. I walk in with, I will say, a plan, which is to engaging the taxonomy, right, is to establish rapport and connectedness with those that I enter into that room with. From this question's perspective, I would say think about it from a goals of care perspective. Physicians and nurses, we all have goals of care. So this is a goal of care for from a spiritual perspective, and person-centered health, body, mind, and spirit. Think of research from that perspective as well, and also look at the linkage of the care that you're offering and how that links to health outcomes. Because again, person-centered care, body, mind, and spirit, and that is our wheelhouse.
Thank you. Kristen, I actually want to address the next question to you. Any pitfalls you would warn against as chaplains begin to read and integrate research into their practice? Because you started to mention or suggest that, yes, you want to take the insights and the gems from each of these studies, but you also recognize they may not be generalizable. Any other pitfalls you would suggest we pay attention to?
I mean, I think the biggest one is just recognizing that not all research is created equal. You need to pay attention to the source of it. I recommend paying attention to who is part of the research team. Is there a chaplain or some sort of spiritually trained person, or is it just a team, not just, but is it a team of doctors and nurses and more of the medical clinicians? It doesn't negate the work they're doing, but it may not fully align with what our approaches and goals are as chaplains if there isn't someone to speak to what we do who's part of that team. Also, even within the chaplaincy research world, we have a growing body of valid research, but a case study of one encounter with one patient or a series of encounters with a single patient does not hold up to, I don't know that we have any randomized controlled trials yet, but you know, like if you look at that hierarchy of research, there's a lot of different levels, and we can't have the same takeaways from one encounter as we can from something national or international that includes thousands of patients. So just paying attention to all of those little details. You can still be curious about anything you read and think about what it means for your individual work in your setting, but you may not be able to draw as many conclusions depending on what those parameters are.
Yeah. Beth or Marilyn?
I would say be gentle with yourself and focus on one area. So don't look at palliative over here, then advanced care planning over here, and then pediatrics over here, but to find an area that you're interested in, and then don't journey alone. So talk to others about, even if you're a chaplain and you don't have any other chaplains around you, call someone else and kind of go through the research together. I have found if you don't journey alone, it makes it easier.
Thank you. One of the comments actually returns to the first question we asked, which is not a question, but a thought. Beth invited creative reframing. I hope that chaplains can reclaim having an agenda. We always go in with an agenda to support patients and families spiritually, and that's okay. And using research to inform how and what we do helps us to better care for patients and families. Thank you. I'm not going to attempt to pronounce your name, Ms. Mickelson, Chaplain Mickelson. Appreciate that comment. I think that's true.
Can I say one to
Go
that,
ahead.
Jeannie?
Yes, Kristen, jump in.
In regards to that first question, I like to think of it as this cycle, which I think either Marilyn or Beth talked about, but like our evidence-based practice feeds into what we do in those one-on-one encounters, and that feeds back into research. So it's this constant round and round, and we're not all called to be researchers, but we are all called to be research literate and to be aware of what the best practices are in our field. So if you can think of it that way, that no, it's not shaping, it's not prescribing to you what you should do in every single patient encounter or family encounter, but research is intended to get those wheels turning and, like Beth said, to have those tools. So if you imagine them constantly feeding into each other, I think that can be helpful in kind of breaking down that dichotomy.
Yeah, and I appreciated, as part of why I invited Beth to be on this panel, is this isn't just on this individual patient encounter level, right? And Marilyn as well, right? We can take this research and we can use it to help inform programs, to help inform how we structure a department, where we put staff, where we don't put staff, all of those kinds of things. And all of you have pointed out that the research doesn't just have to be done on chaplains' care. It can be research from other areas. So Beth's is a perfect example of research done in the area, you know, it's mostly attributed to psychologists, right? Mindfulness practice, integrative medicine, right? That wasn't done with chaplains for the most part. And the PTG, the post-traumatic growth, although it lifts up that faith is an important component, that wasn't, again, conducted by chaplains or with chaplains. And yet there's a kernel in there saying, ooh, is it our role, right, as chaplains to be paying attention to this piece? Aren't we good at that? So there have been several questions about where we go to actually find these research articles. Again, this session today is not a how to do research 101, it's more about the translation. And I know that some folks, as you have mentioned in the comments, don't have access to medical libraries. Let me just mention a couple of resources. Transforming Chaplaincy has a whole library, right? Every month there's a newsletter that goes out that has suggestions and new articles that are published. One of our colleagues publishes one that you can get on his list, right? It's Ehrman, I think is how you pronounce it again, so that they do summaries of these articles, right? And then potentially you can get them through other interlibrary loan, if you have access to a library from your graduate education, right, to your university. There's other ways to also get access to these databases. And most hospitals at least have a health library of some sort, even if it's pretty basic. Trust me, those librarians can do and get almost anything you want, and they can do comprehensive searches for you without you having to do very much. Kind of amazing. Hidden gem. Many of the comments that are coming in are specific to the content area of what our providers had talked about today. I'm going to ask you, we will make sure that you have their email addresses to direct those questions about what are more resources on post-traumatic growth? How do we, learn more about the taxonomy? What are other articles in pediatric care about chaplaincy care? I'm going to ask you to direct those content-specific questions back to those panelists at a later time. Because really the goal of this is to help connect the research that's out there with what do we do with it, right? Oh, here we go. Freda Cohen's comment. This is a statement, not a question, confirming that research does impact how administration will support the chaplain, particularly if it's research coming out of the hospital regarding its particular staff. Interesting. So employee engagement scores, I would imagine, for that institution. how a certain program you're doing, maybe you can measure it and show its impact, right? Or another program that's quite similar to what you're doing. Okay, is reading and applying research ever fun? How does it enhance your own sense of competency and feed you as a clinician? Beth, I want you to start because I've had the closest relationship with you as you've discovered all these areas and then got to design these incredible programs. And I've seen your excitement and just energy. Tell us, this doesn't have to just be like, oh, I got to read research, right?
Yeah,
What would this be like?
yeah, I don't know. Maybe it's because I'm a 5 on the Enneagram, if anybody knows about that, but I love reading the research. Every time a report comes up, I just am so excited about it. But I think it gives you more language about all of this. It gives you more wisdom. It gives you more perspective. In all ways, I feel like it enhances how I can be with patients and families and staff. Even that you would ask, how can it be fun? Of course it's fun.
Marilyn, Kristen?
Yeah, my undergraduate degree was in chemistry, and I'm much more left brain wired actually than I am right brain, which I feel like is kind of unusual in the chaplain world. So it's really awesome for me to get to use that piece of myself in this line of work. So yeah, it's fun, it's intriguing. It definitely allows me to explore my curiosity, my areas of curiosity more. Not that I can't do that, just, you know, with like the qualitative piece of chaplaincy and anecdotes and whatnot. But I love being able to learn from others and envision these bigger projects that could come too, thinking about what research could be done. But yeah, it's intriguing. It stimulates me intellectually in a different way than being in a room with a patient or running a debriefing for staff or whatnot does. So I really like that I have those complementary pieces as part of this profession.
Yeah, interesting. And once you have that in your brain and the language, you also can talk a little bit better to some of your colleagues, which gives you then more connection within the medical setting, which is fun in its own way, right? Or satisfying in terms of those interprofessional relationships. Yeah. Marilyn, we'll let you have the last word on this question.
Yes, it is always fun to me, always. Even when I'm reading the statistics, it's still fun to me. And I would say, as Kristen and Beth had said, it draws you in. And I always think when I'm reading, how can I apply this to my practice? Or how might we integrate this into our department? Or how can we offer better care to patients, families, and staff? And is it generalizable? Can we build upon the research? So it's like I'm constantly reading, and then I have notes everywhere, all over the page, because it just draws you in. And for me, it's helping us to offer that patient-centered care, whether that's a patient, a family member, or a team member, to be focused on them and to say we see them and that they're important. And that's why we want to continue to evolve our vocation.
Nice. So Kristen mentioned this earlier. We ask all of our chaplain residents to undertake a program in research literacy. And part of what they get to do is actually do the exercise that you've just seen these guys do. Look at a question that they have about their area of care. So you're working with bone marrow patients. What don't you know about them? What do you want to improve? Go to the literature, look at it, and then see what the gems are, you know, evaluate the articles, and then apply it in your practice, and then reevaluate it and see if it made it any better or not. So again, just a simple exercise that I think everyone on this call, all, I don't know, 200 of you who are listening, could either do yourselves or suggest to your colleagues. Just take one little error. What question, why is it that I seem to notice that patients who get LVADs, I had a resident do this, adjust in a different way than their caregivers do. Their anxiety seems to come at different points in time. Let me see if there's some literature about adjustment to LVADs and the difference between caregivers and patients themselves. And lo and behold, there's a whole body of literature in that area that then directly informed how this particular chaplain went back and ministered to patients versus families of LVAD patients. when he paid his visit, how quickly, what he focused on. So again, lots of opportunities here. I appreciate our panelists for sharing their brief illustrations and their just joy in integrating research into your practice. We'll do our best to answer your individual questions and direct you back to the panelists accordingly. But join me, I'll be the only one who can clap. Guess nobody else has access to audio. Thank you guys so much, really.
Thank you, everyone. Thank you, Jeannie.
Have a
Thanks,
great
everybody.
Spiritual Care Week, everybody. And don't forget our webinars. Every day there's something coming up. So